Well, thank you. For those of you who have heard me speak before, that was an excellent introduction, but I was actually a full professor in 1989. I joined the faculty many years before that. And some of the people in the audience will attest to that. So today we're going to talk about the new data on the pathogenesis, the diagnosis, and especially about the treatment of IgA nephropathy. Now, we'll start off with a case, and we'll follow this case through. So this is a 19-year-old white male college student, no past medical history. He develops dark urine while playing basketball with his friends. His urine clears up, but a few days later, he's running to class, the dark urine recurs. A local doctor finds him to have a blood pressure of 140/90, no edema. They do a urinalysis. He has 3+ protein, 3+ hematuria, and it turns out, if a lab ever did that, it reports red cell casts along with dysmorphic red cells on microscopic. So we know he has a glomerular disease. He has lab tests done. BUN is 18, creatinine is 1. He's a muscular college student, that's okay. His protein-creatinine ratio is 2.2. He has a kidney biopsy done, and we'll talk about this later. It shows IgA nephropathy. So which statement is true regarding the epidemiology and pathogenesis of IgA? Now, you don't have to use your clickers to vote. You'll do that later on when we do the board review questions, but if you want to raise your hands, you can. If you don't, just, settle in. Just don't fall asleep after lunch. Okay, so which is true? The diagnosis of IgA nephropathy requires a kidney biopsy in 2016. IgA comprises 1% of all biopsies in the United States, but 50% of all biopsies in Asia. The pathogenesis of IgA involves hypergalactosylation of IgA1 at the hinge region of the IgA molecule. Healthy individuals and blood relatives of IgA nephropathy patients have normal levels of galactosylated IgA in their blood. Now, I almost wish we had the audience response system going now to look at the different answers to these questions, but let's go through and show you why the answer is actually number 1. Okay, IgA nephropathy is defined by IgA in the glomerular mesangium and sometimes along the capillary wall of a biopsy. Now, for nephrologists, it's important that you realize that it can be dominant or codominant. If you have IgG and IgA equivalent, that could be IgA nephropathy. It's either dominant or codominant. And you may have other immunoglobulins deposited as well. But nevertheless, you must have IgA there to define the disease at this point. In young people, it presents with episodes of gross hematuria, just like our 19-year-old. In adults, it's more commonly picked up on insurance physicals, pregnancy physicals. Somebody has proteinuria and hematuria, that they get worked up, they get a biopsy, and lo and behold, it's IgA nephropathy. It is clearly not benign recurrent hematuria. Berger described it as this in young people who had recurrent episodes because it's not benign. You get end-stage renal disease in 15 to 20% by 10 years and 30 to 40% by 20 years, and we'll look at the data. There are risk factors for progression, which you have to know about, and the most important thing about therapy is one therapy does not fit everybody. Different people should be treated in a different fashion depending on their risk factors for progression. So if we look at the demographic, oops, did I do that? No. Okay, it's good we got that back because I don't know what HDM1 is. IgA is considered the most common form of idiopathic glomerulonephritis in the world. If you take native kidney biopsies, it makes up actually 5% of all the biopsies in the United States. But if you look at Asia, it's 30% of all biopsies and 40% of all glomerular biopsies. It is rare in African Americans, and we have some understanding of this, and it's common in Native Americans. Now, one of the things that's evolved in the last 5 to 10 years is that we know that patients who have IgA nephropathy have an abnormality of IgA1. They have an abnormality of the immunoglobulin A molecule. It is under galactosylated at the hinge region. It's not hyper. They don't have more galactose. They have fewer galactose residues at the hinge region. And this seems to be one of the primary things that's going on in the disease. So lack of galactosylation at the hinge region. Now, if we look at this, here's a study. Ali Gharabi runs the renal division now at Columbia. If you look at under galactose levels or galactose deficient IgA, you can see IgA nephropathy patients are clearly deficient in galactose residues at the hinge region. The interesting thing is controls are not, but blood relatives are. If you look at spouses of people, they're like controls. But if you look at parents, if you look at SIBs, they also have the same galactose deficient IgA. Here's another study. Christoph Kirillik has done a lot of the work with Ali at Columbia. You'll see his name on a lot of the slides. Here are pediatric controls. The higher we go, the more galactose deficient IgA. Here are the pediatric IgA patients and their blood relatives. Interestingly, if you look at Henoch-Schönlein-Purpura, same thing, controls way up in the pediatric HSP patients and the same thing in their blood relatives. Now we'll come to this again. So it leads to what has been called the multi-hit pathogenesis model. You have galactose deficient IgA, you form antibodies against the galactose deficient IgA, you get immune complex formation, and the immune complexes land in the mesangium and along the capillary wall, and that leads to the proliferation process and eventually the scarring of the glomeruli. Now, one question is, what makes the IgA that is galactose deficient, what makes it antigenic? Because the relatives, they don't have disease. Most of the relatives don't have hematuria, proteinuria, or anything. They just have galactose deficient IgA. So one of the thoughts is that there's oxidative stress, perhaps by viral or other infections, and this oxidative stress makes the IgA1 molecule that has lacking galactose residues more antigenic. Here you see the level of galactose deficient IgA in healthy controls. It's up in the IgA nephropathy patients. Here's another way of looking at it. Same thing. It's up in the patients. If you look at advanced oxidative proteins here, oxidative stress way up in the IgA patients here. And again, this is sulfhydryl groups, so the lower you are, the more oxidative stress. So that may be what happens, but something is happening to the IgA molecule. We also know that in the few studies that have been done on this, if you look at the amount of galactose-deficient IgA in the serum of these patients, it correlates with the outcome of disease. If you take patients with the lowest levels of galactose-deficient IgA in the circulation, they have the best renal survival. If they have more or higher levels of circulating galactose-deficient IgA, they do worse. Higher levels worse, and the highest levels do the worst of all. And this could be a test, a diagnostic test in the future. If you had somebody with hematuria and proteinuria and you couldn't do a biopsy. It's not a commercially available test at this point. The other thing that may be prognostic in the future is looking at antibodies directed against galactose-deficient IgA. If you had those circulating antibodies, you had a worse survival than if you did not. Now, those are both research tests at this point. It's very important, though, that they could be tests clinically in the future as they become commercially available. But right now, there are ways you can look at your patient and make a prognostic guess as to how they're going to do over time. The other thing that's important in pathogenesis now is looking at the genes. So it turns out that there are 15 independent genes that are distinctly associating with IgA nephropathy. This is a GWAS study on 20,000 individuals, again by Christoph Kirillik and the group, led by the group at Columbia. And if you look here at the different genes here, a whole bunch of them light up as being much more significant in this population than control populations. So here's our model again with the reference in here. Some of the genes relate to mucosal innate immunity. Other of the genes relate to adaptive immunity and antibody production. And the third area is some of the genes relate to the complement system. And there is complement deposited with the IgA immune complexes at this time. But again, we may be able in the future to use a genetic model and predict who has IgA nephropathy and who doesn't. At the current time, we need the kidney biopsy. Dr. Renke would be happy about that. So one of the other things that's been looked at is why is it that certain populations have a high incidence of IgA nephropathy and others have a low incidence? And it seems like IgA nephropathy developed someplace here in East Asia and worked its way over, more in Northern Europe, less in Southern Europe, and very little in Africa. If you look at a US population, and you're looking in red at the percentage of IgA in primary renal disease here, primary GN, you can see it's uncommon in African Americans, more common in whites, more common in Native Americans and Asian Americans, people of Asian descent, the most common. And likewise, if you look at the percentage of end-stage renal disease, that's IgA, it increases again. It's most in Asians here. So a lot of people would say somebody of Asian descent comes in with an episode of gross hematuria in a young person, you'd say, hey, this is going to be IgA nephropathy. You can't do that yet. You need the biopsy. Nevertheless, you can make a guess. So what about the survival? What about the survival of patients with IgA nephropathy? So it turns out this is a study looking at the long-term survival in over 1,100 patients. It's a great big series. It's from Nanjing Zhihang Lu's group in Nanjing, China. If you look at the renal survival, not needing dialysis, transplant, etc. here, that 83% here at 10 years, 75% at 15 years, 60-something% at 20 years. The curve is clearly going down. Well, what does this say? This says that when you're treating your patient with IgA nephropathy, they can look great today, but you have to think 20 years in the future. If these are young people, you can't say, well, look, they're fine because they're going to be around long after you're retired and your partners are taking over your practice. So it's important to think about this as a slowly progressive chronic disease in many of the patients, not all. Some come up with crescenteric picture and go downhill quick. Some present very late to clinical attention. But for most of the patients, there's a slow loss. That curve is going down, down, down in terms of renal survival over time. So here's question 2. We have our 19-year-old white male college student. Which features independently predict a poor outcome? Is it the fact that he had episodes of gross hematuria at only 19 years of age? Is it that his proteinuria is a protein-creatinine ratio of 2.2? Is it on biopsy, because all I told you was his biopsy is IgA nephropathy, but is it on biopsy that he has mesangial proliferation in 45% of the glomeruli and endothelial proliferation in 40%? Or is it on biopsy he has an Oxford score, an IgA score of M0, E0, S0, T2? Now, unfortunately, nephrologists have to be pathologists when it comes to IgA and lupus because you just have to know what these things mean. So again, because of time limitations, we're not going to vote on this, but I could see some splay on it. There is one good answer and there's one better answer. The proteinuria is a pretty good answer. The Oxford score is even a better answer, okay? So let's look at why that's so. First of all, proteinuria. This is a study from the Toronto Registry. Now, Dan Catran, who has set up, Heather Wright was the first author, but Dan Catran is the senior author, and he's spent his life working on the Toronto Registry. All the biopsies in the city of Toronto get registered. There's no selection bias. It's not like one center is a referral center. They get them all localized and they're registered together. They follow what happens over time. So this is looking at over 500 patients followed for 78 months. There's a GFR decline per year, as you might expect, and 30% reached end-stage renal disease. Pretty typical population here. If you look at this population, if they started with less than 0.3 grams of proteinuria per day, the renal survival is terrific. If it's 0.3 to 1 gram, it's close. But if you get to 1 to 2 grams a day, you've already got a huge drop-off in survival at 10 years. And if you have 2 to 3 grams, it's worse. And over 3 grams, even worse. Now just think about this. Think about what you know about focal sclerosis or membranous nephropathy. If you got somebody with membranous or focal sclerosis down to a gram of proteinuria, 1.5 grams of proteinuria per day, you'd say you're doing great. That person's going to do fine. But here, over 1 gram of proteinuria in IgA is already the kiss of death for the kidneys. So again, you have to refocus your mind here in terms of thinking of a slowly progressive disease. One of the important things in this study was that regardless of their peak proteinuria, if you could get them down to less than 1 gram of proteinuria per day, whether by an ACE inhibitor, an ARB, using immunosuppression, if you got them down to less than that level, regardless of whether their peak proteinuria was 1 to 2 grams, 2 to 3 grams, or over 3 grams a day, where we see the splay here, but if you got the proteinuria down, they all behave the same. They did equally well. So it tells us reducing proteinuria is important. Proteinuria is a very important prognostic finding, and that's why this person's protein-creatinine ratio is significant. But it also tells us if we can get it down, if we put him on an ACE inhibitor or ARB and it goes all the way down to 1 or less, he's going to do fine over time, or he's going to do better over time than he would otherwise. What about the biopsy? So here's a typical biopsy from an IgA nephropathy patient. You can see a little increase in mesangial cells in several areas, and you can see here IgA deposited in the mesangium. That is the classic biopsy. But what can you have in IgA nephropathy? So this slide shows you some of the different pathologies. Yeah, here's mesangial proliferative, but here is one that has a more proliferative picture, certainly. Here's one with a huge crescent. Here's one with a sclerosing pattern. Here's a focal segmental sclerosing pattern. There's IgA in all of them, and there are, again, deposits by EM. But they're all from IgA patients. And the problem was, for years, people used different scoring systems. People would use the Haas scoring system or the Lee scoring system, and you couldn't compare biopsies from one to another. Moreover, the biopsies weren't necessarily validated with the long-term prognosis of the patients. This led to the Oxford classification. It's important, whenever you say Oxford classification, in your mind, say MEST, M-E-S-T. M is mesangial hypercellularity. If it's less than 50% of the glomeruli, you don't even get your 1 point. If it's over, you get a point, and the more points you get, the worse you're going to do. So that's why this guy who only had 40% mesangial hypercellularity, that's not a bad finding. Endocapillary proliferation, absent or present. Segmental sclerosis, absent or present. Tubulointerstitial fibrosis, less than 25% 0, 25 to 50% 1, over 50% a 2. This is the most heavily weighted, and that's the reason this young guy who had an MEST score that said M0, E0, S0, T2 is bad, because again, the T's are the worst in terms of this. So this has been validated. Now, there are a couple of studies that have looked at this, but this is a meta-analysis of 16 studies, almost 4,000 patients, 570 go to kidney failure. The T category, tubulointerstitial fibrosis, most strongly predict end-stage renal disease over time. The endocapillary proliferation wasn't even predictive. And a number of studies have found that the E is not important, but it's pretty hard to say MEST without, you need some vowel in there, so we leave it in, but again, it's not the important ones. And crescents, which were not in the original classification, when they're looked at, they're significant. So if you had to pick the things that are most important, it's the T for tubulointerstitial fibrosis and C for crescents. Now, you'd have to say MESTC, but nevertheless, if you think of any glomerular disease, tubulointerstitial fibrosis is a bad finding, crescents are a bad finding. That's pretty universal. Recently, the Valiga study has done a validation of this. This is now 1,100 patients in 13 European centers. The follow is 4.7 years, end-stage renal disease in about 10%. Almost everybody's getting ACE inhibitor or ARB, and almost half got steroids or immunosuppression. MST, again, were independent predictors of a lower GFR and renal survival. Even if the GFR was low to start, M and T were still predictive, especially in the group that got just immunosuppressive medication. The most important thing in this study was, though, if you looked at proteinuria, less than 0.5 grams per day did better than if you had 0.5 to 0.9 grams. 0.9 to 1.4 grams did worse, 1.4 to 1.9 did worse. Well, again, we're talking about low levels of proteinuria. So a lot of us are used to saying, well, I'm not going to get so worried if the proteinuria is less than a gram a day. But in this study, it did make a difference. If you're 0.5 grams a day, you did better than if you were 0.5 to 0.9 grams a day. And a lot of people think we should be readjusting our views of what level of proteinuria is worth being aggressive in terms of treating this disease, especially in young people, especially if they're already on the ACE inhibitor ARB at the time. Okay, question 3. What is true about the treatment of IgA in this 19-year-old? Okay? Since he's only 19 years old, he will benefit from tonsillectomy. He should take 3 grams of omega-3 fish oils daily for the rest of his life. He should take an ACE inhibitor or an A2 receptor blocker to reduce both blood pressure and proteinuria. Given a urine protein creatinine ratio of 2.2, he should be given a 6-month course of tapering steroids. Well, there's only one thing here. Well, I shouldn't say there's only one thing here that's not controversial. We'll talk about each of these, but there is no doubt that taking an ACE inhibitor and ARB, every guideline looks at this. If you look at the data, almost every study is positive. KDIGO says ACE inhibitors and ARBs are effective, but steroids are probably effective, less data. Uncertain, fish oils and cyclophosphamide. Ineffective, azathioprine and mycophenolate, tonsillectomy, and antiplatelet agents, which nobody is using nowadays. Now, the problem with KDIGO is several things. One is they had to get an agreement from the 3 people writing each section of this. KDIGO is based, it was written in 2012, and it's based on the data before that, and it takes time till it gets to press. Well, we're already in 2016. So you're talking essentially about data that's 5 years old when you look at this. So let's look at these recommendations here. What would we do in 2016? We would do nothing because I'm not advancing. Is this me? There we go. No, we would do something now. We're saved. Okay, so I'm just going to show you 2 of 24 studies that deal with IgA nephropathy, or as IgA is part of it, looking at ACE inhibitors or ARBs. It's a randomized controlled trial by Manny Praga from Madrid, comparing ACE inhibitor or ARB to other antihypertensive therapy in IgA. They got the same blood pressure in both groups. They looked at patients with a creatinine less than 1.2, 24-hour proteinuria of over 500 milligrams a day. The follow-up is pretty long, 75 months. If you look at those getting a 50% increase in serum creatinine, here's the placebo group. But remember, the placebo group is other antihypertensives at the same blood pressure. Here's the group that got the ACE inhibitor ARB, clearly strongly in favor of the ACE inhibitor ARB. If you look at Rosanna Copo's study, very similar. She looked at those who didn't get to the endpoint of either 30% reduction in baseline creatinine clearance or an increase in proteinuria to nephrotic level, either one. If you take those who got an ACE inhibitor, versus those who got other antihypertensives, again, significant difference here in their outcome. Here you're talking about 4 to 5 years. So all of the studies are pretty much in agreement. An ACE inhibitor, an ARB, decreases proteinuria, slows the progression. If you go back to Heather Reich's study that I showed you from the Toronto Registry, it's very clear reducing that proteinuria makes a major difference. What about tonsillectomy? So this is the question that comes up the most when family members come into the office. You get somebody who has the disease and they're a 22-year-old or a 19-year-old and they've got their parents with them. And as soon as you're done talking to them, the parents immediately say, should he have his tonsils out? I read it on the internet. So, if you had a 22-year-old with big tonsils like this and white spots, you might want to take their tonsils out. But this is the study that's referred to the most. This is a non-randomized retrospective study that looked at a population of about 120 or so patients who had IgA nephropathy, biopsy proven. They're followed a very long time. This is the group that got tonsillectomy, and this is renal survival. This is the group that didn't get tonsillectomy, renal survival. Now, I would point out 2 things. This is retrospective, non-randomized trial. Again, it may suggest a hypothesis, but it certainly doesn't prove anything. The other thing that is probably the most important thing when you look at this graph, when do the curves split? How far out do you have to be before the curves split? This is not days, this is months. 120 months, 10 years is how far you have to go out. So if you have somebody coming into your office and they have a creatinine of 2.2, a protein creatinine ratio of 2.2, or they have significant proteinuria, they have an elevated creatinine, you do the biopsy, it's got a bad MEST score, an Oxford score on it, you can't wait 10 years and say, okay, I'm going to take out your tonsils and see what happens. That guy's going to be in renal failure, he'll have a transplant long before that. In general, I say if you've had bad tonsillitis, I would take out there. If you have multiple episodes, especially if you're in your 20s already, where it's unusual, yeah, that would make sense. But for most people, the data just is not there at this point that tonsillectomy makes a difference. What about fish oils? So there are good fish oils and bad fish oils. Eicosapentaenoic acid and docosahexaenoic acid, of course, are good fish oils. Those are our omega-3 fish oils. Cyclooxygenases and lipoxygenases are bad players in terms of fish oils. And the problem is when you go to one of the over-the-counter health food stores and you buy your fish oils, you don't know what you're getting. In fact, you don't even know the amounts that you're getting of any of these. I always like to show this table here that somebody put together here. It looks at the amount of omega-3 fish oils here in a serving. So if you're eating a lot of herring, doesn't matter if you're east coast of the United States or west coast. If you're eating a lot of herring, you're going to get a lot of fish oils. Well, where do they eat a lot of herring? In Amsterdam. Yeah, I was recently just a few weeks ago in Amsterdam. Yeah, they eat a lot of herring there, but do they eat herring on the east coast or west coast? No, nobody in the United States eats herring. So what about salmon? Yeah, if you don't like steak and you go to Ruth's Chris's, you get the salmon. So if you're eating Chinook salmon, you're loaded with fish oils. If you're eating sockeye salmon, you don't get nearly as much. Well, the only place in the United States that I know where they know what, in New York City, when they say they've given you wild salmon, they did a DNA test on that already. It was in the New York Times. Out of the 12 fancy restaurants that they tested, 10 of them of the wild salmon were actually farm raised. One was equivocal and one was truly wild. They can't tell you whether it's wild or not. They certainly can't tell you whether it's Chinook or sockeye or king salmon. Yeah, in Alaska they can tell you, Seattle they can tell you. And if you're relying on tuna fish, if you're eating canned tuna fish to try to get your fish oils, all you're getting is mercury. You're not getting any fish oils at all. So, and that's the reason. If you look again at the fish oils, over-the-counter stuff, they're so variable. So, given that we have a varied amount in here, what about the actual studies? These are the best of the studies in terms of positivity. This is Jim Donadio's series of studies from the Mayo Clinics, and his collaborative group, looking at a 2-year period of Omicor, which is, highly omega-3 fish oils, high content, when he looked at the percentage who did not have a 50% increase in serum creatinine, the fish oil group did better than the placebo group over time. When he looked at survival free of end-stage renal disease, the fish oil group did better. Survival free of doubling the creatinine, the fish oil group did better than placebo. So that's a strongly positive study. Now let's look at another study. This is Ron Hogg's study. It's a pediatric study, but the pediatric age group went all the way up to 40 years old. I don't think if you're 38 years old, you're in the pediatric group, but they couldn't get enough people into it, so they kept raising the age. But in any case, if you look at these people with biopsy-proven IgA, GFR over 50, and protein creatinine ratio over a half a gram a day, 33 patients got every other day steroids for 3 months. 32 got fish oils, 31 got placebo. When you look out at 2 years looking for a drop in GFR, 2 of the steroid patients, 8 of the fish oil patients had a drop in GFR, and placebo was 6. The fish oils were doing worse than the placebo and a lot worse than the steroids. Given this is the equivocal data we have for fish oils. It does not support the use of fish oils. I tell my patients, if they want to take fish oils, that's fine. Don't stop your ACE inhibitor or your ARB because you want to take fish oils. Don't go out and get a tonsillectomy and take fish oils and not do anything else that we tell you, because again, the evidence is softer. Now, what about steroids? We have 3 randomized control trials, and then we have the STOP-IgA trial that recently came out and I'll talk about. So Patsy's trial has the longest follow. He treated 86 patients. Half of them got steroids for 6 months. I'm not going to go through the individual regimens because each study had a different regimen, but they were all about 6 months of steroids with a tapering dose. Treats them in here, follows them long term. If they got steroids here, that they had much better results without doubling their creatinine than if they did not get steroids. Strong study, except only 40% of the patients got an ACE inhibitor. That was the big criticism when they started the study. We weren't using ACE inhibitors on everybody. So people said, I'm not going to buy that just at this point. Second study from China, but it's from Peking #1 Hospital. 63 patients here, biopsy-proven IgA, significant proteinuria, and relatively preserved GFR. Everybody got an ACE inhibitor, Cilazapril. Half of them got steroids, again, tapered down over 6 months. So let's look at the results here. Not having a 50% increase in serum creatinine. Here's the ACE inhibitor group here. This is the group that had the combination of the ACE inhibitor and the steroids. Not having a 25% reduction in GFR. Again, the steroid group did better. Proteinuria reduction better in the steroid group. Positive study for steroids. Third study, different Italian group. Now, some people will say, well, wait a minute, Cilazapril, I've never used it in my life. I don't even know if you can get it in the United States, but we certainly use Ramipril. So here you're looking at all the patients, these 97 patients all had at least a gram of proteinuria and a preserved GFR that they got their blood pressure titrated down to less than 120/80. Their proteinuria was down with the Ramipril. Half get randomized to steroids. The other half just stay on the Ramipril. If you look at the group here that got steroids, 1 of 48 had end-stage renal disease at 8 years. The control group, 8 of 49. 8-year renal survival, 98% versus 70% randomized control trial. So again, 3 relatively strongly positive trials. Now, in a minute or two, I'm going to have to explain how does that click with the STOP-IgA trial, which recently came out in the New England Journal. The other thing I will say is, if you look at the Baliga study again here, corticosteroids usage, and this again is looking at this retrospectively, but if they looked at patients in that large study cohort here from Europe that they followed over time, they looked at a nested propensity-matched case control study, 184 pairs, half got steroids plus blockers of the renin-angiotensin system. The others got just the blockers. So these are matched pairs here. Steroids were associated with a superior outcome, even if you stratified for GFR and proteinuria. The GFR loss was less in the steroid-treated than in the steroid-untreated. Proteinuria here went down more in a greater percentage of the patients who had steroids. This just shows you survival was better in the steroid-treated group. If you took people with a low GFR, it was better in the steroid-treated group. If you took people with a high GFR, it was better in the steroid-treated group. So again, it's retrospective, but it's case-controlled, but again, it's positive. Now, what about other immunosuppressives? So we do have one study that's been referred to an awful lot, and that's, people call it the Ballardy study, just like they, for members, people talk about the Ponticelli study. They call it the Ballardy study because Ballardy was the first author. It was from Manchester, UK. They took a group of people with progressive IgA who were likely to do badly. Half of them got 3 months of cyclophosphamide followed by a longer-term azathioprine. The other group did not get the immunosuppressives. The results were dramatic in favor of the immunosuppression. The problems were it was only 38 patients total, and everybody said, how did the control group do so badly if you took this population in our hands? And when I say everybody, I mean I was in London at the time that this came out, and everybody in London said our patients don't do that badly. They may do badly in Manchester, but they don't do badly in London with this. Anyway, we do know that if you give if you give azathioprine plus steroids versus steroids alone, POTSI has done this study. This is now in 200 patients followed over 5 years. There is absolutely no difference in renal survival. They both have a good renal survival, but remember, they both got the steroid regimen here that he recommended. So the evidence that cyclophosphamide works, even though KDIGO says it does, is very weak. You're talking about one study, which is, again, grossly underpowered. Now, the last thing, in your syllabus, I've put in the data on mycophenolate, the individual studies. But for time's sake, we've condensed them here. There are 3 trials that are worth talking about with mycophenolate. The first I'm going to talk about for a specific reason. So Gersh Frisch was actually on an NKF of Canada fellowship at Columbia with us, and we were going to do a control randomized trial of mycophenolate in IgA. It was going to be 100 patients. Half got placebo capsules, these little gray placebo capsules, which I can tell you cost more than the mycophenolate did. They were very expensive to make them up. But the problem was we had to stop the study early. We actually had 40 patients totally enrolled, 32 finished the study. But the problem was that the serum creatinine for entry, we allowed them in with a creatinine up to 2.4. The estimated GFR was 39. Everybody, even though they were on ACE inhibitor, they had a lot of proteinuria, everybody was progressing, both the MMF and the placebo arm. It was beyond the point of no return. If you're going to do a study in IgA, you can't take people with creatinines of 2 to 3. You can't take people who have had a progressive course already because most of those are going to progress anyway. Now, the other 2 studies are very interesting because Mises study is in a Belgian group. Tang's study is in a Hong Kong group. Here you look at creatinine 1.43 versus 1.59. Here, proteinuria 1.6 grams per day, 1.8. Blood pressure is the same. Everybody's on an ACE inhibitor, ARB. The follow-up is longer in this group, but this is a positive study. Clearly, Tang's study had 10% of the MMF patients had end-stage renal disease. 45% of the controls did. In Mises' study, there was absolutely no difference. What's the difference between these studies? The population. The only thing you can say is, this is a Belgian population, this is a Chinese population, maybe they behave differently, or maybe it's because all of these studies are grossly underpowered. You're talking about 30, 40 patients in a study. And anything can happen when you have those numbers that are that low. So it doesn't speak in favor of MMF, but it doesn't speak against MMF. It turns out it's neutral for MMF at this point. We don't know if it would make a difference or not. Now, there are a few special cases I want to mention before I go on to the newer studies. One, if you have IgA deposits in somebody who looks just like minimal change, they have very heavy proteinuria, complete foot process effacement, treat the patient as if they had minimal change. They will respond the same way. Second, if you have somebody who has IgA nephropathy with gross hematuria, many of these patients come in with an elevated creatinine, they have AKI, it usually resolves on its own. The vast majority don't even need a biopsy, it's going to resolve. Third, if you have IgA nephropathy with true crescents in many of the glomeruli, whether it's 30%, 40%, or 50%, doesn't matter, that's a bad disease already. There you're thinking about vigorous therapy with perhaps cyclophosphamide or rituximab. And again, you're talking about limited data in terms of this, but that's a different disease than the vast majority of patients we talk about. And finally, if you have IgA nephropathy with advanced CKD, the creatinine's slowly progressed over time, and the creatinine's 3, forget it. That person is not going to respond to any of these things. Just slowly prepare them with long-term course being transplantation. Now let's look at one or two newer studies in the last few minutes. So the STOP-IgA trial here, which is it's a German study using multi-center here population. They looked at a large patient population of IgA. They got a 6-month run-in with ACE inhibitors or ARBs to get the blood pressure less than 125/75. They all got statins. If your blood pressure went down and your proteinuria went down to less than 750 milligrams a day, you weren't in the study. And only in the study if your proteinuria was over 750 milligrams with that low blood pressure. If your proteinuria was very heavy, over 3.5 grams, you weren't in the study. This is important because, again, only the minority of the patients who were initially coming into the run-in phase ever got into the study for the randomization. If your GFR was over 60 cc's a minute, you got every other day steroids for 6 months with pulses of IV methylprednisolone. It was like the POTSI regimen. If your GFR was low, you got the oral cyclophosphamide switched to azathioprine, like the Ballardy regimen. If you look at the end results here, this is response in terms of lowering proteinuria with stable creatinine. Here you're looking at supportive care plus immunosuppression being better than supportive care, just blood pressure control with an ACE inhibitor, ARB, or statin. If you looked at progression, though, in terms of who had a decreased GFR at the end of the study, there was no significant difference. So if we look at this whole thing here, you don't have this. These are just quotes from the study. The bottom line is that they said only in the rare patient with persistent proteinuria would we consider corticosteroid monotherapy pending the results of more controlled trials. We're not going to get a lot more trials that have that many patients. My take on this is actually one of my associates working at the Glomerular Center at Columbia put this together. Many high-risk patients respond to supportive care. Immunosuppression can be associated with adverse events. More patients receiving immunosuppression achieved a complete remission of proteinuria here, and some of the patients will progress despite standard care. So we're left still saying that there is a group of patients who will benefit from steroid therapy. I still think if you have over a certain amount of proteinuria, whether it's 500 milligrams, 750, or a gram, you would benefit from getting steroid therapy for 6 months. It's pretty benign if you use it on an alternate day regimen. One thing that's new for the future is looking at budesonide. Budesonide is a presumably non-absorbed steroid that works in the ileocecal area in the Peyer's patches. Here's a pilot study, high dose, lower dose versus placebo. And when you look at the results here of this, mean change in protein creatinine ratio up in the placebo, down in the other groups, in the groups that were treated. Mean change in GFR, again, minus 4.7, positive in the other two groups. The withdrawals were higher in the budesonide group. Adverse events were about the same. Suggestive enough that there is an ongoing trial now of looking at budesonide. Now again, we don't know whether it's going to pan out in a larger study here, but still, it is suggestive. And finally, rituximab. Since we reach for rituximab all the time now, and Dr. Niles will tell us in a few minutes whether he reaches for it in ANCA-positive RPGN, that there is some data that suggests it might be beneficial. There are case reports here, certainly, that there are no large randomized trials. There is a multi-center randomized control trial here that looked at patients with over a gram of proteinuria on ACE inhibitor ARB for at least 2 months. The mean proteinuria was 2.1 grams a day, the mean creatinine 1.5. 34 patients received the rituximab versus placebo. At 1 year, no difference in creatinine, proteinuria, or remission rate. Now, there was a slightly higher proteinuria and creatinine in the rituximab group, but again, there was no progression. So given this is not a positive study. This is a study, we've been involved in a lot of studies with the Mayo Clinic and Fernando Fervenza, and Fernando does good studies. I mean, like his membranous study on cyclosporin, the Mentor trial, cyclosporin versus rituximab is a terrific trial. So the guys at Columbia love that. We hated this study. It was placebo versus rituximab in a group that was going to be progressive. You can't get people to use placebo. They say, well, can we get rituximab? Yeah, you can get it, I mean, if your insurance approves it, you're fine in terms it's the cost, it's nothing else. So in any case, this is already going to impress. I would just say that there is no positive data based on this at this point. So what's my therapy for IgA? Everybody gets an ACE inhibitor or ARB. I strongly consider using a statin if I possibly can get away with it. I think they should be on a low, which means not high, protein diet. I will try to get everybody's blood pressure down to less than 130/80. If you want to aim for 120/75 in a young person, that's fine with me. Tonsillectomy if they've had frequent tonsillitis. Fish oils for those who want them, but not to replace the other therapy. If they have mild disease, normal GFR, less than 0.5 gram of proteinuria per day, and a good biopsy, I would just follow them at this point. Wait till the other studies are done. Let's see what happens. If they have moderate to severe disease, an abnormal GFR, over 1 gram of proteinuria per day, you can see I don't know what to do with 0.5 to 1 gram per day. Or a biopsy that suggests a bad prognosis by the MEST Oxford score, or they have crescenteric GN. I usually recommend for those patients to get steroids for 6 months at a tapering dose, and again, we use an every other day regimen. You could consider cyclophosphamide and steroids, though again, the STOP-IgA trial did not bear out the results of VALOR-D. You could use MMF, again, the data's equivocal. You could consider ACTH or budesonide on limited data. The most important thing is if you have a high creatinine and the biopsy all has glomerulosclerosis and tubular interstitial fibrosis, don't use immunosuppression in that patient. It is very unlikely you're going to help them. Save the immunosuppression for transplant. So I was very surprised a number of years back. I was in Maine at the time, and I saw this on top of a supermarket, IgA, and I said, my goodness, here those people are so progressive up in Bangor. They're already tuned into IgA nephropathy. They even know about IgA cheese slices. But, of course, this is the International Grocers Association. It's all over Australia, and now it's already down to New York. It's working its way down across the country. In any case, when you see IgA on top of a supermarket, just think about how much progress we've made in IgA nephropathy in the last 4 or 5 years. And I think I've already overstayed my time limit here, so I'll stop here. Thank you.